is an associate professor in the Department of Health and Rehabilitation Sciences at the University of Nebraska Medical Center. She currently teaches neuromuscular and professional expertise practice in the physical therapy curriculum. She has over 25 years of experience as a clinician with an emphasis on neurologic adult and pediatric practice, and is a board-certified clinical specialist in neurologic physical therapy since 2009. She was a co-author on a paper published in 2014 on the cross-sectional assessment of stroke rehab in Nebraska hospitals. She has served on the Nebraska Stroke Advisory Council Steering Committee, the Mission Lifeline Task Force for Nebraska, and of course on our AHA Post-Acute Stroke Rehab Standards Writing Group. So welcome, Kathy.
Can you hear me okay? Okay. Good morning. I've spoken to a group in Montana before, virtually, that have not been to see your state, and flying in yesterday and seeing the mountains was just beautiful. And flat staters who are here this morning can appreciate what I'm saying, since I'm from Nebraska. So it's a privilege to be a part of the writing group that developed the standards. Spent the last 3 years being involved with these folks who are very passionate about stroke care, and just being around them was really uplifting to see their real interest in making post-acute care better in our country. And so my job this morning is to present those standards and the work of the committee to all of you. So we'll start with just a few facts. Likely you know these already. The number of individuals having strokes in the US is still pretty high, right? And though there's a decline in the relative rate of stroke deaths, in the early 2000s, there's still a majority of survivors who do not recover completely and need rehabilitation. And about 2 out of 3 will receive rehabilitation services after they're hospitalized. And studies have documented 35 to 40% of stroke survivors have limitations in basic activities of daily living. So just your important things like bed mobility and transfers. And more than 50% of stroke survivors will have limitations in these more complex instrumental activities like making a meal, for example. So where are they going after they have been discharged? Winstein's article here in 2016 gave us some of the numbers. Highest is usually going to skilled nursing, and followed by inpatient rehab facilities and home health. So those would be the most common settings. And multiple transitions of care are common for this particular population. And we also know that cost has been an issue since the 90s, impacting utilization patterns. So I've seen it, you've probably seen it, cost and insurance coverage are often a major factor in post-acute care discharge decision making, which is unfortunate. All right, so the rehab system has some gaps that we've found and that lead us to less quality of care for these folks. So ASA and AHA frequently reevaluate the literature and then issue some of these policy statements or guidelines for us to follow, and they can be really helpful. And this one in particular got my eye because way down at the very bottom here, it does talk about stroke rehabilitation and recovery at the very last sentence. And that's always going to make therapists stand up and do a little cheer when we get some sorts of guidelines for stroke rehabilitation specifically. And so in this paper, a key recommendation was early rehab should be provided, and that there's a lack of structure that's a barrier to effective post-acute care. And so some of the gaps, challenges, and barriers to providing this kind of care were outlined, and lack of structure was one. Another gap was there's no quality metrics currently for post-acute care to reduce complications of stroke. And then another challenge was providing post-stroke essential education about prevention and complications. So especially during these transitions of care that our patients are going through. So a lack of structure, lack of metrics, and inadequate coordination of stroke education were three big barriers. And that undermines our ability to provide good care. And then looking at stroke rehabilitation, specifically, we had a nice guideline that came out in 2016, authored by Carolyn Winstein and a large group of nurses and therapists and physicians as the authors. And this excellent guideline is just full of good information about stroke. Covers prevention and management of stroke comorbidities, assessment tools, and treatment. And so I highly recommend this as something to be used as a resource. I use it to teach my physical therapy students about stroke and use it as a reference frequently. And in this piece, they recommend organized interprofessional care in teams, and that stroke survivors should receive rehab with the right intensity, an intensity commensurate with their anticipated tolerance and what they can benefit from. And lots of research continues to come out about appropriate intensity, especially in the therapy world. All right, so given the great need for stroke rehab services and improving our quality of post-acute care, then we started writing standards about 3 years ago, and we have developed these in 6 categories that we'll go through here today. So we have program management, personnel education, patient education and support, care coordination, medical management, and quality improvement. So I'll go through the first 5 of these, and then Jana will pick up on the 6th one and finish up. And some recent survey data has shown us that people are interested in some help to get started with these kind of standards. And so they told us things like, well, we might need some templates or some guidance documents, ideas for education opportunities for our staff. And so today, for the standards, we're going to go through those and provide some possible resources that you could use that are available out there. All right, so the first program standard is program management. And this is the systematic and operational oversight of the program itself. And then the elements of the standard are listed right below that. And we know I just said best to have your rehab delivered in an interdisciplinary or interprofessional team of providers with training in stroke. And it takes a sustained, coordinated effort by a team and a leader. And so the first standard involves trying to get people on the committee or this interprofessional committee to oversee the stroke program at the facility. And this includes somebody that would be a stroke champion. And that's the leader who has a passion for improving care of stroke patients and understands the need for structures and processes to help improve quality. Okay? All right, so for patient or audience engagement, who's most likely to serve as a stroke rehab program champion in your facility when you think about your particular setting? Okay. Very good. All right, got most people in here. So it looks like some therapy providers, some sort of a therapist or a director of rehab, and then some other. It would be interesting to know who the other are. So that stroke rehab champion is really critical in getting this team together to work well. This is part of the elements of that standard 1. It's just another way to have a structure and it lays out process as well. So this would be just a sample program charter, and it can be a meeting charter or a meeting protocol that sets up the goals and sort of some of the processes that the committee would follow in stroke rehab. And participants in the Mission Lifeline PAC initiative will have access to documents like these in the healthcare network. And Jana will talk more about this later. Standard 2 is personnel education, and this is the stroke education requirements for the staff who are providing care to individuals with stroke. And so the facility should have an education policy that requires annual stroke education for the team members providing direct and indirect care, and documenting those requirements are being met. And then direct patient care staff should receive additional education, and that would be, the therapists, the nurses, and physicians that would be specific to the level of care and their level of expertise in stroke. So at that link, you will be able to find some educational resources for healthcare professionals that is just really excellent, and it has different kinds of videos, guidelines that have been published, webinars, and some patient-focused materials that I thought were really great, and they can help with achieving some of the standards, including this personnel education standard. Okay, so 3 out of 6 of the standards address direct patient care. This patient education, there's one on care coordination and one on medical management. And this one is patient caregiver education, and that the patient or caregiver assessment is completed, so have they gone through and kind of like a checklist, what kind of education are we providing them? And then using the teach-back method to assess the patient and caregiver's ability to safely perform things like self-care and medication is important. And then another one would be that education is provided in a variety of formats that meet the needs of the patient for their healthcare literacy level as well as their primary language. Which stroke topics would you like to see staff education materials created? So go ahead and fill in your suggestion, especially regarding what you may not have access to and that we could develop. Okay. Awesome. Looks like emotional issues is an important one, as well as cognitive issues. A lot of our patients do have depression and anxiety. All right, thank you. All right, so the patient and caregiver information, this is kind of the what type of information, should include risk factors in stroke prevention, stroke warning signs and symptoms, and then some of the things that were just on the slide before on the poll everywhere, common physical, emotional, cognitive, and sexual consequences of stroke. Individuals' lifestyle coaching to help people understand secondary prevention would be another need for education. And of note, the last 2 on this were identified as gaps from as higher needs in a recent Montana survey. And then some other areas for information sharing: med management, recognition of changes to emotional state, and the importance of keeping follow-up appointments, because all of this can be a bit overwhelming to patients and families. And they may need to have things repeated multiple times, as we know, for that to kind of take a hold on their memory. And I have something I did want to link for you. Yeah, see if we can get this up. The Hope Stroke Recovery Guide, we actually have hard copies of out at the booth. So if you want to see the nicely published version, the softcover version, it's really beautiful. Or you can download the Stroke Recovery Guide free online. Let's see if it comes up. Thank you. I would not have been able to figure that out. So I appreciate your expertise. So this is just the table of contents that I had pulled up so that you can see that it has chapters on self-advocacy. There's aphasia, prevention, nutrition, family caregiver pieces, and just really a nice tool, a little bit of exercise at the last chapter has. Okay, back on track. All right, so standard number 4 is care coordination, and this is the ability of the stroke rehab program to coordinate and deliver treatment across the continuum. So the stroke program should have a documented process to facilitate transitions to and from any level of care, and it should have an organized clinical care team with weekly team conferences, and this is to ensure that the team has an organized structure for preparing and coordinating care and coming up with the timeline for discharge. And then also, it does say that the clinical team should perform a social determinants of health evaluation so that we're able to monitor what kinds of non-medical factors may be influencing and impacting their ability to achieve a quality outcome. And we know that this one will probably be a little more challenging for the smaller facilities. But communication and coordination of care is even more important when you have lots of people coming in and out of your building. So if you're using contract therapists, coordinating that is just really critical. Part of this structures and processes that can help this would be documentation using a medical record that is going to allow information to be accessible 24/7 by all team members. And also an assessment of gaps in family caregiver readiness to provide their care at home should be done at least 3 days before discharge. And discharge planning should be beginning at admission, and the whole team would be working on that together. And I'll show you, hopefully, some resources. I'm not going to go into this one. This is a little more therapist-oriented, but in terms of trying to document standardized assessments and have some results in your medical record, PTs and OTs especially can go into this SRA lab.org, and the Rehabilitation Measures database has a ton of good tests and measures available. You can go into the search box, type in either the name of the test you're looking for, or you can do a kind of a filter approach with the population of stroke and picking out what you're interested in. Maybe it's depression. And so that will pull up several different tests that you could use in order to do that assessment with. It's really great. And it will post also a sample of the test for you. You could download. Most of them are free. Regarding the discharge planning, AHA has a couple of good resources, so we'll see if we can pull this up. This discharge checklist is really nice. And it just is going to help people to identify some of the gaps in their learning, a kind of nice piece to go through and let people figure out what they know about their stroke. And answering those questions, and if they can't answer it, then there's some teaching to be done. So I kind of like that checklist. Be helpful. And then there's a discharge planning guide also that you can link into. A couple of other things in care coordination would be that there's somehow an updated list of available community resources being kept at the facility, and also that the stroke rehab program would contact by telephone the patient or caregivers within 2 business days of being discharged home in order to make sure that things are going okay. How soon does your facility make telephone contact with patients or caregivers currently after they're discharged? Kind of curious to know. So we had quite a discussion about this particular element of the standard in the writing group, of what we felt was going to be a matter of safety for patients, and we landed on 2 business days because of the safety aspect. I'm sure there are probably good reasons for choosing a little longer length of time, perhaps because you need them to get home and find out what they didn't figure out while they were in rehab. And several, it looks like, do not contact their patients, or it's an unknown. So this will be a standard that that will take some effort to meet, but it's, I think, very worthwhile. In terms of the resources in the community, there's probably things available in Montana already that you just need to be able to access. I know in Nebraska, I just put this up as a sample that the Nebraska Stroke Association shows in terms of on their website, services available. You see at the bottom, there are different types of things that you can click on, and then the website will pull up what's in the state, and you can figure out what's close to you. And on the right, it also talks about the support group meetings that are being held in various areas of Nebraska. And so it's a great resource to find the kinds of things that the standard is talking about. Okay, and then medical management is standard number 5, and this is the ability of the program to provide medical care and rehabilitation. So the program should have speech, OT, PT available to provide care 5 or more days a week, either in person or via telehealth. And then the stroke rehab program would have available for consult and assessment, social workers, dietary, and behavioral mental health professionals. So the whole question is, which professionals are most difficult to hire in your area? Because we recognize that rural areas sometimes struggle to fill these positions. I would say Nebraska has very similar difficulties in that speech language pathologists are hard to find in rural Nebraska, as well as our mental health practitioners. Right, thank you. So the stroke program should have these staff available 24/7 to assess and manage medical complications. That would be the physicians or the APP. And then they should be on site 3 days a week. And then it's recommended but not required for a PM&R physician or a neurologist to consult. Desirable but not required. And then most, I would say, the skilled nursing often have their registered nurse on site. This would require a registered nurse 24/7 for patient safety. Stroke program has a documented protocol in place to manage medical complications, including a plan to expedite transfers to acute, and then incorporating current evidence-based guidelines relevant to medical management of stroke. And that one, in terms of documenting how that's being met, you could use things like order sets or protocols or pathways that reflect evidence-based guidelines. Then appropriate assessments and screenings are completed in a timely fashion and treatment is initiated. And so screens or assessments of screen for swallow, skin integrity, fall risk, cognition, and communication are some of the examples that are given. All right, and then quality improvement will be the 6th standard, and Jana is going to go ahead and explain that one.
All right, thank you, Kathy. Yes, so as Kathy mentioned, the 6th and final category of the standards is quality improvement. and just making sure that your stroke rehab program has some way of evaluating your current performance and looking for areas to improve. And with that, it would include collecting and tracking regular compliance data specific to your stroke rehab population, and then routinely sharing that information with your interprofessional committee, at least on a quarterly basis, to look at where you can improve and celebrate where you are doing well. And as mentioned, when the interprofessional committee is looking at that data, the idea would be that they be the group that would help to determine what kind of performance improvement plans are needed. And then also that in looking at your data, you would actively be developing different tools and to help you with meeting the standards, such as post-discharge telephone scripts and different checklists, handoff reports, EMR templates, etc. And we are also working to develop a lot of these tools and templates that will be made available to sites that are working on implementing the standards. So right now, does your facility currently collect and monitor quality improvement data specific to the stroke rehab population? Are you separating out that stroke rehab population in any way? Well, I'm pleasantly surprised to find that the majority of folks are. I was assuming that you're probably collecting a lot of data. I know you're collecting a lot of data around your patients, but I'm glad to see that many of you are really zeroing in on that stroke rehab population already. And regarding the measures that are included in our standards, it was a bit of a challenge for the writing committee to decide to really narrow it down to specific measures, because there's so many things that you could measure with stroke rehab, and each patient is so different in what they may or may not need as far as therapy is concerned. And it worked out well that in the fall of 22, I think, or just not that long ago anyways, we had this clinical performance measures for stroke rehabilitation paper, which was released. And this also closely followed those 2016 AHA stroke rehab and recovery guidelines, and a writing group that developed standards or measures based on those. So the facilities that are part of our project will be quarterly, they'll be monitoring the percentage of stroke rehab patients who had aphasia who received speech language therapy. They'll be monitoring the education that their stroke rehab patients receive. Depression screening, of course, is very important, making sure that that is taking place. Also, for those stroke rehab patients who have impaired mobility, are they getting the adequate VTE prophylaxis? And there is one built in too about, are you doing a follow-up phone call within 2 business days after discharge home? It'll be very interesting to see the responses that we'll get from this in our in the platform where we measure the metrics at. And I should add too that there's nothing punitive for sites that are part of this project if you are not meeting these measures. The goal would be that you'd be improving your program as you go along. And in some cases, if we find that the majority of facilities aren't doing that 2-day phone call, and this is why, we potentially could look at even revising our standards a bit based on some of those findings. And then for patients who come into your rehab program, are they seen by a medical provider within 24 hours of admission? So in conclusion, regarding the standards, it's very clear that having a large team effort taking care of these patients, that those patients are going to have much better outcomes, and that communication and coordination amongst the team members is extremely, extremely important as well. So in closing, I'm going to share some more about the Mission Lifeline Post-Acute Care Initiative. This phase of our project actually kicked off in July of last year, and it will go through June of 24. And I myself am working with facilities in Montana and also Nebraska and North Dakota. We're hoping to recruit 15 facilities here in Montana, a mixture of skilled nursing facilities, critical access hospital swing bed type facilities, as well as inpatient rehab facilities. And then we're going to be working with 20 in Nebraska and hopefully 15 in North Dakota. And in Montana, we have, I think, 6 spots remaining. So we're hoping that some of you that are here today would be interested in joining us in this initiative. Some of the items we'll be working on with the participating sites, we have a post-acute care stroke community which we have built. It's like a peer-to-peer sort of platform where you can communicate with one another, ask if anybody has an example of a protocol for this or a best practice for that, and we're really hoping that a lot of sharing happens that way. We also will house our toolkit that will help facilities in meeting the standards on this platform as well. And then we have the quality and certification tool. That's the data collection platform where facilities will go in once a quarter and input their data for their stroke patients. And it will be not individual patient data, it'll be aggregated numerator denominator type data for your entire stroke rehab population. So hopefully it won't consume too much time of the individual that has to enter those. And of course, we will help you with all of that. And then we have a dashboard, which is going to go live here in June of this year, where you can compare yourself to the other sites that are part of the project to see how you perform. We'll be also, throughout the project, having different activities, educational offerings, both in-person and virtual in each of the states. And we'll be working with our participating sites to develop out toolkits, guides, and lots of education. And we have a public awareness campaign that we're going to be kicking off as well here in the next year of the project, with really a goal of making the public aware that it matters where you get your rehab at after a stroke, and trying to highlight as well those facilities that are part of our project and the fact that they are actively working to build and grow a stroke rehab program. Also, sites who each year you can receive a $10,000 participation stipend. So we do have still some spots open for the first year of the project. So in total, you could get a $20,000 participation stipend. For those of you joining from Iowa, that is a 3-year project. So those facilities can receive up to $30,000 total. And of course, you'll get some quality improvement support from us throughout the project. And you'll get to be part of monthly learning collaborative calls. In some cases, you might be sharing some best practices from your facility, or else learning from others that are part of the project. And that's also where we'll get feedback from all of you on what we could best create and build to help facilities in meeting the standards in the future. And then also just increase collaboration between your facility and the other links in the chain of survival for stroke patients, such as those hospitals that are referring those patients out for rehab. Any questions for Kathleen or I?
Maybe it was
Oh,
that
this one,
Yes,
yes.
so the top
This
there.
is just testing out the healthcare network. That is that peer-to-peer platform network. So in the future, like right now, this is just open to our 4 states that are part of the project, the healthcare network page. And then in the future, the goal is that these standards would be deployed nationwide eventually, and more would join. So we're just getting all the bugs out of the system in this initial phase currently. And the same with the standards themselves. We're kind of working through them. They'll be a working document in a way, as we learn from all of you. And certainly you are not excluded from being part of the project if you cannot meet each and every standard. We realize that won't be possible in all facilities. And for those standards that your facility can't meet, we will just ask for information on why can't you meet it? Why isn't it feasible? Is there something we could help develop that would make it more feasible for you? And the standards themselves are available. I don't think we have a public-facing web page that they're linked to. I can find a way I'll include them in this PowerPoint before we send it out to all of you after the conference as well. So, yes? Well, I'm glad you asked. Yep. Oh, yes. So someone online asked, how do we become participants of this project? You can give me a call. My phone number is there, or my email. And if you want to take a picture of this screen, or if you don't and we'll be sending these slides out as well after the conference, and you could really email back Nia, who most of your communication for the conference has been coming from, and she can connect you with me as well. If you are in Iowa by some chance, my colleague Madeline will be working specifically with those sites. So we'll connect you to her if needed. Any other questions? Yeah.
I really appreciate how you've addressed the depression aspect. I was at a stroke conference recently in Wyoming at the Cheyenne Regional Medical Center, and their stroke program director, Dr. Collar, she's a neurologist, she addressed that in her slide, and it was nice to see. The company I work for, they're just so focused on like the muscular and the neuromuscular and the function. So my question is, first of all, are you all working with like neurologists and physiatrists in the area? Are they included in the initiative? And is there like a process you recommend, or what have you seen as far as like maybe scales they're using to assess or screen for depression?
Well, we have physiatrists that were part of our writing committee, of course, and most commonly, like the PHQ-9 is the most common tool I feel that is being used. And we aren't specifying a certain tool, just as long as it's an evidence-based tool that they are using. But we will, throughout the project, we'll have some facilities do some best practice sharing with that. And that's something they would decide with their interdisciplinary team. That's one of the things they would meet on and decide what they're going to use to meet that standard. And assuming most would end up going with the PHQ-9 screening tool. Yeah.
I just have a question. All those slides, they have physical therapists, occupational therapists, doctors, everything. But where does the pharmacy lie in that? It really is a big part of it. I am a pharmacist, but
Yeah.
I also have, my dad suffered a stroke a year ago. I manage his meds along with my mom, but I do know a lot of patients that come into our pharmacy that they're trying to live independently and they cannot manage their meds. So I'm just curious why pharmacists aren't part of that big collaboration, because it really is. I mean, even behavioral health-wise, I know there's some days that he's super depressed. Some days I always say that some days I have Stroke Bob and some days I have my dad back. But most of the time I have Stroke Bob. So we fiddle with his medications a lot. Luckily we have doctors that'll allow us to, kind of do what we can with it. But I do notice that there is a gap in our little circle there.
Yeah. And I'm trying to think, in our actual standards document, they're probably listed as like a PRN member of like the interdisciplinary team. But that's a good point. I mean, that's something we should consider, that could have been an oversight, where it'd be good to have that person at the table, because all those patients are going to be on meds, and that would be a great perspective to have included for sure.